Hi, my name is Rosemary Hill. I'm a nurse specialized in wound, ostomy, and continence care. I currently work in North Vancouver with Vancouver Coastal Health. I also have the pleasure of working with Dr. Josh Douglas, an infectious disease specialist. And we've had the opportunity to use MolecuLight in our practice. And we've been learning many interesting things about our patients and their wounds. And so today I want to talk to you a little bit about some of the things that we've been discovering in the periwound region of our patients, and the bacterial load that's there. So let's take a moment. Maybe for those of you who are not familiar with the device, this is the MolecuLight. It's a handheld device that will emit a fluorescence light. And we usually darken the room as necessary and shine the fluorescent light on the wound. And it gives us a picture, real-time point-of-care detection and a localization of bioburden. In other words, if it's 10 to the 4 or greater, there'll be a red fluorescence that will be noted. So let's take a moment, and I think what you're going to find interesting is how we looked at our wound care practices. Many of us typically will use normal saline to cleanse our wound. And in fact, I believe we're suggesting at least 100 mils of wound cleansing. Sometimes it's referred to as wound hygiene. However, sometimes I think we might be missing the peri-wound area. So take this gentleman, he was a 77-year-old fellow who had a midline surgical dehiscence. His actual wound bed is fairly clear, but the peri-wound area really lit up. And you realize that that amount of bacteria that's there is moderate to heavy growth if we were to swab that. And so it lets me wonder about the, how that bacteria can easily fall into the existing wound, and perhaps it's opened my eyes to appropriate wound hygiene and wound cleansing. So let's look at the next 5 cases. And this was a lady who fell and she sustained quite a substantial skin tear all the way down her leg. And so when she presented in Emerge with this, I brought my MolecuLight and shone it on her leg. And sure enough, there was some red fluorescing coming back. So I thought, all right, let's see if I can clean that area, that whole wound, with normal saline. After I did that, I re-imaged, and I still had the red fluorescence showing up. And so I said to myself, I wonder if I use something a little bit stronger. And I had access to a low concentration of a sodium hypochlorite solution, and I used that, and interestingly enough, that did eliminate the red fluorescence. And so that was a kind of a very good learning for me. I found the MolecuLight a helpful tool to tell me what's going on with my peri-wound, but how well am I cleansing my wounds. This was again a gentleman who had a diabetic foot ulcer on the plantar surface of his foot. And actually, after I took his dressing off, there was considerable red fluorescence noted. And again, I used saline, re-imaged, still present, but again, I reached for something a little bit stronger and was able to eliminate the red fluorescence. This gentleman was a chef, and he's on his legs for long periods of time and had developed some really nasty venous leg ulcers when he presented to our clinic. And his particular MolecuLight image really had a preponderance of both the red fluorescence, but it also had the cyan green, and that really speaks to the degree of Pseudomonas. So you'll notice in that image, the baseline image, there's a lot of cyan green and also red fluorescence. So I took my saline, and with care and watching his comfort level, began to cleanse his wound thoroughly. After I did that with the normal saline, I re-imaged. And I have to say there wasn't much of a difference. Again, I reached for a slightly stronger, the same low concentrated sodium hypochlorite solution. And you can see how quickly it eradicated the Pseudomonas. So again, I'm learning what works and what will dissipate or diminish that bacterial load on the peri-wound. Maybe this slide will quickly tell you about, we just looked at 10 wounds, and out of those 10, when you cleansed with saline, the fluorescence was still there. But when you reached for a low concentration of the sodium chloride solute, it certainly indicated that it was able to cleanse some of that red fluorescence. Let's look at this case, a 69-year-old male with long-standing venous ulcers. And again, his was very heavy with Pseudomonas. So you see that the cyan color and that burden to the wound bed. And then again, we did saline with not much of a difference, but again, participated with using the low concentrated sodium hypochlorite solution. So I have a feeling that this MolecuLight is really impacting my practice as it pertains to peri-wound hygiene. But I've also taken the opportunity of showing the patient, because I know sometimes there's a tenderness and a sensitivity, and I want to let them know that there can be some value in cleansing their wound properly in terms of reducing the bacterial load. So I engage the patient when I'm using the tool as well. This was a gentleman who sustained a pressure injury following he'd had a subdural hematoma, and he was found down. And again, I just want to show you that was his eschar area that was later debrided by a surgeon. But again, we had some fluorescence showing up, and we reached to doing some debridement. I talk to you about the peri-wound, but actually sometimes it's the wound edge. And I'd like us to think more about what's going on at the wound edge and what care do we need to take. So it's interesting now. Let's take a moment to conclude and reflect back on those cases that I shared with you today. Really, bacterial red and or cyan fluorescence was present in 100% of the wounds in the peri-wound area. And this bacterial load persisted even after the typical standard of care of cleansing with normal saline. This is concerning, given that red fluorescence equates to a bacterial load of greater than 10 to the 4. We're leaving that bacteria behind. Think back to the gentleman where the red fluorescence was present, and even after cleansing, it's still present. I think that 30% also of the wounds required debridement after cleansing with the low concentration of the sodium hypochlorite solution. So this study, or these cases, really demonstrate that bacteria is located outside of the wound bed and poses as a cross-contamination risk. Our current best practices are cleanse with saline in terms of wound hygiene, but yet with that cleansing, we're leaving behind considerable bacteria. So I would encourage you to rethink the peri-wound area. For me, having the MolecuLight has absolutely opened my eyes to not just the wound, but the peri-wound, and also looking at the wound edge and what is happening there in terms of bacterial load. I am getting that real point in time picture of what's actually happening at the wound bed. And so I would encourage you today. I conclude with saying, open your eyes to what's going on around the edge and the peri-wound area in some of your complex chronic wounds. Thank you.